Good afternoon, good evening, good morning, wherever you are tuning in from. Welcome to our Neurology for Vets Journal Club webinar series, where we're speaking with authors of recently published studies in neuroimaging. And these webinars are sponsored by Hallmark Veterinary Imaging, so thanks very much to them. Today, we're thrilled to have Dr. Daniel Lowe with us discussing his study. The title of that study is Longitudinal Assessment and Cost-Benefit Analysis of Prophylactic Fenestration in Chondrodystrophic Dogs with follow-up MRI. Just as a way of introduction to Daniel, Daniel qualified from the Royal Veterinary College in 2019 and spent a couple of years in small animal general practice in North Lincolnshire. And then completed a rotating internship in a referral hospital in the Northwest before joining Frank Pet Surgeons, initially as a surgical intern before gaining the ECVS residency position at Frank and Swift. So hello to both those practices. He is an RCVS advanced practitioner in small animal surgery. And is keenly interested in soft tissue surgery, orthopedics, and neurosurgery. Currently, he's actively researching intervertebral disc extrusion, cranial cruciate ligament disease, humeral intracondylar fissure, and applied machine learning. Kind of a broad set of topics there, Daniel. His study has been completed in collaboration with Swift Referrals, St. George's Vets, Blaze Veterinary Referral Hospital, and the University of Hanover. So hello to all of those centers. And welcome, Daniel. Thanks for giving up your time to come and join us and tell us about your study.
Thank you for the introduction, Simon, and thank you to Laurent and Simon for the opportunity and the platform to present our research. So Simon's already gone through the title of our paper, Longitudinal Assessment, Cost-Benefit Analysis of Prophylactic Fenestration in Chondrodystrophic Dogs with follow-up MRI. If you have already read our study, then thank you very much for reading it. And if you haven't, I hope this presentation sufficiently summarizes everything for you. Brief introduction on the condition. Intervertebral disc extrusion is one of the most common canine myelopathies around, mostly affecting young and chondrodystrophic dogs. If it happens once, and up to 19.2% rate of recurrence has been reported. And not only does this cause pain and morbidity to the dog, but it is also very distressing to animal owners as well. Because of this, prophylactic fenestration has been proposed as a means of potentially reducing the rate of recurrence. This refers to the procedure where the nuclei of non-extruded intervertebral discs are removed. It's fundamentally the same technique as fenestration of an already extruded intervertebral disc, but conceptually a little bit different. It can be done either from a lateral or dorsal approach, and it can be done with a blade or power-assisted techniques. But thus far, no technique has been shown to remove 100% of all the nuclear material in situ. Despite decades of research, this procedure still remains very controversial amongst clinicians performing neurosurgery. And broadly speaking, there are three camps, whereby the first camp, surgeons don't routinely perform any prophylactic fenestration. In the second camp, some clinicians will routinely fenestrate cranial and caudal to the site of decompression, whereas in the third camp, some clinicians will routinely perform multi-level, meaning 6-level fenestration from T11 to L3. So prophylactic procedures, as I mentioned, they are conceptually different from a therapeutic procedure, and is also not the same as fenestrating an already extruded disc. Prophylaxis comes from the Greek word for protector, and when we perform a prophylactic procedure, we're not trying to treat, but we're trying to prevent disease. So when we do this, what we have to do is we need to weigh the risks and benefits of performing a procedure on essentially normal tissue that's not causing a problem, and how much this can potentially benefit the animal moving forward. Specifically in these circumstances, the benefit in this case would be preventing another episode of extrusion for a dog that's already suffered one episode of intervertebral disc extrusion. But we need to weigh all the risks associated with this, and the risks include the direct morbidity associated with the extra surgical time and the procedures, the adverse events associated with fenestration, the direct costs of performing prophylactic fenestration, and the actual risk of another extrusion taking place. What we don't actually know to say whether prophylactic fenestration is useful or not is we don't actually know what the true recurrence rate of intervertebral disc extrusion is without prophylactic fenestration, and therefore we don't actually know what the true protective effect of this procedure is. All existing studies are limited because none of them have any systematic active surveillance. What I mean by that is that all these studies use variable follow-up methodologies. Some of them will assume that if the dog never came back for a follow-up examination or follow-up imaging, that the dog must have been all right. There are many reasons why this is patently not true. The dog may have had a silent extrusion without any clinical signs. It might have had clinical signs, but the client may have failed to pick up on this. Maybe the client picked up on it, but misinterpreted the signs as something else, like abdominal pain. Maybe the client or the referring vet picked up on it, but chose to manage it by themselves. Maybe they referred the dog, but they referred it to another hospital, or hopefully not, but sometimes some of these dogs are euthanized when they experience recurrent extrusion. So there are many reasons why making this assumption will systematically underestimate the true rate of recurrence. Similarly, some studies assume that if the dog develops recurrent spinal pain or pelvic limb neurological deficits, that it must have been another extrusion. Suter and others, in their paper in Vet Record a few years ago, they show that most of these dogs with recurrent deficits after having had one surgery, most of them will indeed have an extrusion at the distant site, but not all of them do. So by making this assumption, you will start to systematically overestimate the true rate of recurrence, and therefore there is this bidirectional risk of bias in all the existing studies out there. Active surveillance is really, really important, and in part this study was inspired by one of my supervisors. He always says, if you do not properly follow up, you do not know. And he's not just referring to prophylactic fenestration. This applies to all or many surgical conditions where we used to think as a profession we were doing a great job, but as time goes by and we start to follow them up better, we realize that maybe we're not doing as good a job as we used to think we are. Prophylactic gastropexy is a good example. The initial studies all reported really, really good outcomes, 100% success rate, 0% recurrence rate, but newer studies who have performed post-mortem examination or follow-up ultrasound of the gastropexy site, we now know that gastropexies do fail and dogs do get GDV again, and it's definitely not a 100% successful procedure. For TPRO complications, initial studies reported really, really good complication rates, very, very low complication rates with this procedure. But what was happening was we were performing the TPRO and sending them away back to the referring vets. Currently, right now, most places will perform surgery and systematically radiograph every dog that comes back. And the complication rates have easily doubled because of that. It isn't because the newer studies are doing it less well. It's simply because we're performing this active surveillance now. And finally, for BOA surgery, we used to think we were doing a good job, but newer studies that have performed repeat CT of the pharynx or repeat laryngoscopy, we find that some of these procedures, we're getting wound dehiscence, the soft palates returning back to its normal size. Basically, we're not doing as good a job as we think we are. So our study design, we conducted a retrospective dual center observational study, and we observed fenestrated and non-fenestrated discs between 2 time points on dogs who have had 2 sets of MRIs. To be included in this study, you had to be a chondrodystrophic dog with 2 episodes of T11 to L7 intervertebral disc extrusion. Each episode had to be documented on MRI, and this allowed us to observe non-extruded intervertebral disc between the first and the second time point. We excluded anything that could risk misclassification. For example, a dispersive extrusion where the extruded disc could not be identified, those dogs were excluded. Any dogs with significant concurrent non-extrusion myelopathies that could potentially confound, those were excluded. And dogs who had an unsuccessful outcome from the first episode, management of the first episode, were also excluded. The exposure and outcome in this study were kept simple. The disc was either fenestrated or not, and the disc either survived or did not. Because the proportional hazards assumption was violated, we used an accelerated failure time model instead of a Cox survival model. This is an example of a dog that entered this study, and I'll illustrate how we observe these discs between the first and the second MRI. So this 3-year-old Dachshund presented in 2020 with a T13L1 extrusion, and this was documented on the first MRI. That disc itself does not enter the study because it has already extruded, but this allows all the remaining discs between T11 and L7 to enter the study, and from the clinical records, we know their fenestration status. When this dog comes back 3 years later, having experienced an L1, L2, and L4, L5 extrusion, we document the survival status of each disc, and knowing the fenestration status, we can perform analysis to observe the effect of prophylactic fenestration. We perform cost-benefit analysis with the following assumptions. We estimated the direct cost of fenestration using fixed price HEMI fees from the UK, where it is fairly standard to offer fixed pricing now and to publish these prices online. We simulated a number of scenarios. We used the point estimate as well as the 95% upper and lower confidence intervals to simulate a range of possible effects of fenestration. Essentially, we're trying to simulate a range of plausibilities, and we're not saying that the results of our study are the final word on how effective fenestration is. We simulate if fenestration was mildly protective, strongly protective, or not protective at all. We then simulate the following other scenarios and come up with a range of 72 simulations on how cost-effective this procedure is. In our case, we did not account for the morbidity of the procedure because there's no good way of doing so. We also did not account for any of the adverse events because not only is this rare, but there were very few fenestration procedures done. So it wouldn't be fair to account for this. So really, the only thing we accounted for are the direct costs of the procedure themselves. To calculate the benefit, we calculated the forecasted cost after fenestration and compared this to if the dog had no fenestration and calculated this in British pounds. We ended up with 80 chondrodystrophic dogs, and this allowed us to observe 633 intervertebral discs in situ. 5% of these discs received prophylactic fenestration. A roughly equal proportion of both groups of intervertebral discs were subsequently observed to extrude on follow-up MRI, and on multivariable analysis, prophylactic fenestration was not associated with extended survival of the intervertebral disc, with a time ratio of 1.17. However, the 95% confidence interval overlapped with 1, and so this was not a statistically significant finding. What we did find, though, was that a unitary increase in Fuhrman grade was associated with reduced survival of the intervertebral disc with a time ratio of 0.34, meaning for every 1 unit increase, the survival time of an intervertebral disc decreased by roughly 2/3. Moving on to cost-benefit analysis. In our baseline cost-benefit analysis, we simulated the best, the base, and the worst-case scenarios. Prophylactic fenestration was only cost-effective in the best-case scenario when a strong protective effect of prophylactic fenestration was assumed. In the other two scenarios, prophylactic fenestration was not cost-effective from 1 to 6 sites. Notably, in the base case, prophylactic fenestration was assumed to be weakly protective, but what we can see is that the weak protection offered by a weakly protective procedure did not outweigh the cumulative costs of the fenestration itself, and it still remained not cost-effective. In analysis of Fuhrman grade 4 discs, we show that prophylactic fenestration was cost-effective in the best-case scenario when you assume it has a strong protective effect, but this was only true up until a certain point. And for 5 and 6 site fenestration, it was no longer cost-effective. For the base and the worst-case scenarios, it was rarely cost-effective in Fuhrman grade 4 discs. In contrast, and somewhat counterintuitively, in Fuhrman grade 3 discs, prophylactic fenestration was much more likely to be cost-effective and was cost-effective in almost all of the best and base case scenarios, bar 1. It was less cost-effective in the worst-case scenario, assuming no protective effect. And finally, when simulating in an external population with a more run-of-the-mill risk of re-extrusion, prophylactic fenestration did not emerge as cost-effective in any of the simulated scenarios. So overall, in 72 of our simulations, prophylactic fenestration was not cost-effective in 2/3 of them and cost-effective in the remaining third. We also noticed the following trends. It was consistently not cost-effective in the general population of susceptible dogs, whether you assume a strong protective effect or not. It actually seemed to be more cost-effective in Furman grade 3 compared to Furman grade 4 intervertebral discs. This suggests that the risk of extrusion of a grade 4 disc is actually so high that no matter what you do, you can't outrun the fact that it is going to subsequently extrude. Another trend we noticed is that as you increase the number of fenestrated intervertebral discs, generally the cost effectiveness of the procedure decreases. So the main finding from our study was that fenestration had no influence on the rate of recurrent extrusion, and really our findings are not that novel. Suter and others also reported that there was no association between fenestration and the risk of recurrent extrusion in their study in vet record using a similar follow-up MRI methodology. Of course, both our studies are limited by the same retrospective study design and uncontrolled study design. In both our studies, the quality of fenestration also was almost certainly varied, and neither of our studies, although we use active surveillance, neither of our studies use systematic surveillance in that only a select population of dogs underwent a second MRI. So neither of our studies reflects the general population of dogs out there who are susceptible to recurrent extrusion. Specific to our study, for cost-benefit analysis, we probably overestimated the cost savings from fenestration. We assumed that every episode of re-extrusion resulted in decompressive surgery to calculate the cost-benefit from fenestration, whereas in the real world, this does not always happen. And we know that less than 100% of dogs with re-extrusion end up having a second surgery. Going back to my point about active surveillance is essential, but it is also very humbling. We can add prophylactic fenestration to the list of procedures where we collectively as a profession think we're doing very well, but maybe we're not doing as well as we think we are. While our study cannot be used to say fenestration is effective or not, we hope our study challenges the pre-existing dogma about how effective prophylactic fenestration is. All we are suggesting is that follow-up imaging is necessary before we can make a firm conclusion about the effectiveness of prophylactic fenestration. We hope that our study is a stepping stone to the study that we all need, and this study must be a prospective randomized trial. It has to have a standardized fenestration technique. We have to quantify how much nuclear material was removed with fenestration, and we must perform follow-up imaging of all dogs, including asymptomatic dogs, to remove all the biases that I have already mentioned. If anyone's thinking of doing this study and getting this through an ethics board, I wish you good luck. What we can conclude, though, from our study is that 6-level fenestration is extremely unlikely to be cost-effective under any of the scenarios that we've tested. We do show that Furman grade is a very strong predictor of extrusion risk, which might be useful in the clinic for advising clients on their dog's re-extrusion risk. And finally, we show that maybe targeted fenestration instead of multi-level fenestration is the way to go. Maybe fenestrating Furman grade 3 disc might be a viable way forward instead of indiscriminately fenestrating any disc that you see. Once again, I'd like to acknowledge Hallmark for the platform to present our work, and thank you to Laurent, Simon, and everyone for listening.
Thank you very much, Daniel. Great presentation, and I have to commend you because, tackling some dogma is always the most interesting study. It's very easy just to repeat things and really questioning what, as we say, dogma is really, really important. While we get some questions, I just have a few. So you're not looking at the disc, but you suspect to be the origin of the extrusion. You're looking at the others when you're looking at, the benefit of extrusion. So you haven't looked whether or not you should fenestrate the disc that you suspect to be the issue. You didn't look at that. Because that's always a question that we always get. Should we fenestrate the disc that you suspect? The other thing I wanted to quickly ask you is, did you look at the location of for the one that re-herniated, not re-herniated, for the one that extruded, the location in relation to the original affected disc? Because you mentioned probably targeted fenestration. So did you look if they are more likely to be close to the affected disc, or they're actually distant?
There are some studies that report an increased risk of extrusion adjacent to an extruded disc or adjacent to a fenestrated disc. We did analyze this in the multivariable model, but it didn't show up as significant. So we didn't find that fenestrating or natural extrusion predisposed to adjacent site extrusion. It was one of the things I was looking at and thought might be found, but we didn't find that.
So there was not a site close. There was not relation to the first extruded disc. You couldn't say they're usually close to it or not close to it. So the idea of having a targeted, we haven't reached any conclusion for that, to have a targeted, fenestration on that. Good. Let me put some question from the audience. The first one, you can also read it. It's about the recurrence interval in days between dog that underwent fenestration but wood that did not, considering that a mean of 231 days was reported without specifying the category. Did you see any difference between the two groups?
So I don't have that data to hand. It will be in my Excel sheet somewhere. But we did analyze that in the multivariable model. We didn't analyze it at the dog level. We did perform statistics to make sure that there were no dog level confounders, but primarily the analysis was at the disc level. We looked at the disc to see whether it was fenestrated or not, and how long it survived between the first MRI and the second.
Okay. No, that's really good. I think one question that everyone wants to ask you is, I understand, more need to be done, to reach conclusion. At the moment, for your case, what are you doing? Or if a vet asks you, Daniel, I know you've done a study, I read your paper, what do you recommend at this stage with the knowledge that you gather?
So with this study's findings, maybe I'd be more likely to prophylactically fenestrate a disc that's within the site of decompression that's easily accessible, so either cranial or caudal. And maybe if it was Furman grade 3 or 4, I'd consider it. I'd consider it more in a Furman grade 3 compared to a Furman grade 4. Our findings suggest that it's more cost effective in 3 than in 4, but it doesn't mean you can't go and fenestrate Furman grade 4 disc. I wouldn't go searching for a disc that's distant from the site of decompression just to perform extra dissection, just to go for it if it was just the one that was degenerate. But yes, maybe we can start to perform targeted fenestration as a new approach.
And will you always fenestrate the disc that you see? It's not always easy, but the one that you suspect to be the origin, will you always fenestrate it, or won't you?
So I don't always fenestrate it, and this is in part because this is how I am being trained. During my residency, my supervisors don't routinely fenestrate the disc unless they suspect that there may be a lot of residual nuclear material and that the dog will benefit from same site fenestration.
Yeah. And I presume the difference with the degree of degeneration may be due to the fact that, we've all been there. They are really little dog. The disc space is very narrowed. With advanced degeneration, the disc space is even narrower. And I always say often the width of the disc space is just about the width of an 11 blade. And you can, just about put the blade, maybe tweak it a bit. And you could argue, what are we doing there? Does it make any difference? So it may also explain that because it's difficult to fenestrate, this kind of disc, for sure. Let's see another question. Any long-term data pointing toward long-term complication of fenestration, disc space collapse, and subsequent protrusion of the annulus?
Yep. So this is more a general question. It's not one that our study can answer. I'm not aware of any long-term data suggesting complications with fenestration. It's been proposed in biomechanical studies, to my knowledge, but I haven't seen any studies showing conclusively that there are definitely long-term adverse effects of fenestration. Regarding protrusion of the annulus, this is something that I have seen. I noticed that if you perform fenestration in a disc, sometimes when you repeat imaging, you do see a slight bulging of the annulus. It's non to minimally compressive, and it almost never causes a problem. So yes, I do notice it. I don't know what Laurent and Simon think, but I never seen it to be a problem.
Yeah, I mean, the only complication we see now, I mean, doing reporting is mostly, it's not very common, discospondylitis at the site of, fenestration. That's that's probably the only one I will spring to my mind, to be honest. Very good. Simon, do you have any other question you wanted to ask Daniel? You're on mute.
There you go. All right. Sorry. Just quickly, with the lack of positive benefit of fenestration, does it bring into question the mechanism of fenestration? Like, should we be looking more at power-assisted fenestration than blade-assisted?
Yep. I think the effectiveness of this procedure will be related to how effectively you remove all the nuclear material. But like Laurent said, it depends on which disc you go for, because if you're going for a highly degenerate disc that has a collapsed disc space with sclerotic end plates, you might not get out much despite your best efforts. But I think a power-assisted technique that's standardized will be able to get more out and potentially make it more effective.
Yeah. All right. Well, thank you very much, Daniel. I really appreciate that. Your insights into the study have been valuable, and I would echo what Laurent said. I really congratulate you on putting this study together. There's not many subjects in veterinary neurology that get people as, I want to use the word excited, but I don't want that to be misinterpreted, but get people very interested, and that is fenestration. That's been an ongoing challenge for years, and so kudos to you for addressing that in the way that you did it. Excellent. Thank you again to Hallmark for sponsoring this. Tune in again next month for another webinar. In the meantime, we will post this one for those that are been unable to see it, and we will also put it on our website and put it on our podcast channel. So thank you very much from Laurent and I, and again, thank you, Daniel.
Thanks, Daniel. Have a good day. Bye-bye.
Thank you, everyone.